I do want to get started. So welcome to this course on innovative approaches for engaging patients and improving decision-making in the era of precision medicine and now COVID-19. I'm very glad that you all decided to join us, and it sounds like you've all got, you're all experts in your own right in different ways. So this is going to be more of a kind of an engagement type of course where we all share and learn from each other. So it's not just I'm not the professor the way I am with my students in my university. I'm really want to learn from you as well. And I'm going to, in fact, caution you that a lot of what I'm talking about today is work in progress. So it's things that we are trying to innovate and work on and tease out. And so I'm really hoping that you will be engaged and be interested enough that you'll allow me to pick your brains. So that's sort of the exchange we have here. So my name is Amaya Isa again, and I'm a professor of pharmaceutical sciences and health policy at the University of Sciences in Philadelphia. I am the founding director of a center called Personalized Precision Medicine and Targeted Therapeutics, P²MT² for short, which I founded in 2001 and then brought it with me when I joined the university in Philadelphia in 2011. It was one of the very first centers in this field, and our mission is to develop the evidence base for and promote informed decision-making about and accelerate knowledge translation of personalized medicine into meaningful health outcomes. And given all of the advances that are being made these days in precision medicine, I always like to say that our mission is really to make the revolutionary routine. So I've been doing research and decision-making surrounding precision medicine for over 20 years now. I actually started out with a PhD in neuroscience and later on added other degrees and other training, including health policy, including medical ethics, as well as a degree in master's in public health, and sort of combined everything together and have been working in this area of what I call precision medicine, decision science for over 20 years now. So these are a few of the papers that have come out of my center. And now that I've introduced myself and you have all very kindly introduced yourselves, what I'd like for all of us to do is to take a moment, and I'm going to call on one person and then you get to call on the next person afterwards, is to, if you haven't introduced yourself because you're new, I think we have at least one new person who's just joining us. Welcome, Cindy. Then I'd like you to say your name and your organization as well as your role. But for those of you who've already introduced yourselves, or maybe as you can do it again since we have a new person, share with us one hack or one positive thing that you have discovered or rediscovered during this pandemic time. So I'm going to start, and I've already introduced myself. I'm Amalia, I'm our course instructor for today. And for me, I've been enjoying a virtual journal club that meets by Zoom once a month. And I'm also reading more for leisure again, and I'm in a book club. So that's my hack. So I am going to call on Cindy, who's just joined us, to introduce herself, tell us your name and what institution you're from and your role in the organization, and share with us a hack. And then Cindy will call on, I guess, who's going to be on deck next. How about Lauren?
Hi, everyone.
So, Cindy?
Yeah, hi, everyone. Can you hear me?
Yes, we can.
Oh, hi. What a surprise. I thought this is like a large short course meeting, but I have really haven't expected for myself to, to introduce myself. But anyway, so my name is Cindy Gao, and I'm an executive director with Pharmacogenomic International, an open health company. I'm not sure how many people are familiar with Pharmacogenomic. So actually, I'm also the lead for Pharmacogenomic Asia Pacific business. I've been in HUR for about 20 years in HUR consulting field. And also what you mentioned, you would like us to share some experience about the COVID-19, post-COVID-19
Well, a hack or like a productivity hack or some other hack or something positive that you have either discovered or rediscovered during this time.
Yeah, I feel like from my observation, I feel like especially my role is a little bit unique. I'm working with my global colleagues, working on global projects, and as well as some local, working with local affiliates on those country-specific projects. So I can observe, the difference and the development strategy development differences across different continents and countries. And in terms of our HUR, or I do observe that it's kind of positive to get more attention or draw more attention or awareness on real world evidence or the patient reported outcomes in terms of the actual COVID-19 patients outcomes. So that's something like I can, I observe, and also from my clients.
Okay, thank you. Okay, Lauren, why don't you share with us a hack? Feel free to say your name and organization again because Cindy hadn't joined us earlier.
Sure. Hi, Lauren Levitt. So I work at Mass General Hospital in Boston, Massachusetts. I didn't mention before though my role. So I actually work in the Health Decision Sciences Center along with Karen Sapuka, and we do a lot of work on implementation of shared decision making. So conducting shared decision making efforts across Mass General Brigham, so within the city of Boston. We do a lot of clinician training and research activities to measure the impact of shared decision making on patients. So we've been remote since March. So I don't actually live in the city. I live outside north of the city in a suburb. And one thing I discovered I've always wanted to do, but during the pandemic, we were able to build a garden. So we had a garden, a vegetable garden for this last spring and summer. And it was an interesting experience. I definitely learned what to do better next time. But we did successfully grow some cucumbers, which was great. The tomatoes didn't grow as well as I wanted, so we'll try again. But so that's something we spent a bit of our time with, at least early on too, that we hadn't done prior.
That's wonderful. Yeah, no, that's a terrific project, and tomatoes are finicky. Okay, who do you want to call on next?
Sarah?
Okay. So I'm Sarah. I'm a GYN Oncology Clinical Fellow at the University of Chicago. I'm spending my year in research, and actually it's kind of focused on shared decision making in advanced recurrent gynecologic cancers. We don't know a lot of information about what patients want when they're facing these terrible diseases. So I'm doing a lot of work with that, and also the health economic side of it. One thing I discovered during COVID is I started a book club, but what I thought was one of the cooler things at our sort of organizations, our Society for Gyn-Onc, so many faculty across the country kind of chipped in, and they now have this virtual series of education where you have the best leaders in the field, and now weekly we have boot camp lectures, and I think that that's been a huge gain for our field as far as being able to learn about different aspects of GYN oncology. So I guess COVID has pushed us to move forward in that realm.
Okay, wonderful. Who would you like to call on next?
Calling Kate.
Hi, I'm Kate. I'm a decision scientist at a molecular diagnostic company called Foundation Medicine. And my family, as everyone's is scattered all over the place. And so we have started a weekly online board game night. So there's this cool website called Board Game Arena, and they have like the board games that you would play physically, but it's all digitized. And it's actually like way more time than I got with my brothers and my parents before the pandemic. So that's a bright spot. And I'll call on Kristalia.
Yep. Hi, I'm Kristalia Pandiri. I'm located in Rotterdam. I'm working in Pharmacogenomic, the same company as Cindy. I'm a research consultant and health economist by training. One thing, actually, what I did discover during the quarantine, it was most around food. So I had virtual dinners for first time with my friends and family because we didn't have the chance to be all together. And yeah, learned to cook very good recipes, traditional things that only the mom would cook. So yeah, in terms of work, I was impressed by the way that everyone got on board, and we were already working virtually. I mean, client meetings and all this, but like converting all the work interactions in the virtual world, and it seemed like it could, yeah, work perfectly fine like before. Yeah, it was an interesting thing to see.
Thank you, Cristelia. So did you already make, or did you learn how to make moussaka?
Yes, I did.
one,
And
one of my favorites.
yeah, nice. Actually, the thing is that during that quarantine, I'm also in quarantine. We're also at home, working from home already from March, like most of the people. But the thing is that Easter in Greece is a big thing, and this Easter nobody was with families. So all my brother and sister, that we got all at home cooking things that we never did before. Like, yeah. So it was an interesting experience.
Great. Who do you want to call on next?
Let me see the list. Randall.
Okay, Randall, thank you for joining us. So what we're doing is we're giving our names, the organizations we're with, city we're living in or based in, and what our role is in the organization. Also speaking about one hack or positive thing that we discovered or rediscovered during this pandemic time. So the floor is yours, Randall. Welcome.
Wonderful, thank you. So my name is Randy Grout. I am a general pediatrician and a informatician and health services researcher. At Indiana University and the Regan Street Institute, and then our local urban safety net health system here in Indianapolis, Indiana. I primarily have worked before in clinical decision support, and I especially work in helping the researchers who want to do any type of research involving the electronic record, and a lot of that ends up being with some type of decision support, how to implement that and evaluate that. Something kind of a hack or something I've learned off the top of my head, just how well working at home can work. I used to, think I needed to go in the office to do something, but I could do quite a bit from home. Just setting up a little office and computer at home, and it's that works out well. But I do value those traditional relationships, the hallway conversations in the office, and so I've been able to, on the side, kind of meet up with some of my kind of close office buddies, and value those relationships, but still be able to accomplish the work just fine from kind of the virtual side.
Terrific, thank you. I think the one person who hasn't spoken yet is Anne. So Randy, if you could call on Anne.
I'm going to choose Anne.
There we go.
Hi, thanks. I'm Ann Harada. I'm at the University of Southern California, Schaefer Center for Health Policy and Economics. I'm managing director there, as well as a research scientist, and I have been doing some work in improving cancer care through artificial intelligence, and also looking at precision medicine as potential options for improving cancer care. One of the things that I've learned during the pandemic is I guess one of the luxuries that we've discovered is having a lot more time, not having to commute. And in Los Angeles, that's where we spend quite a bit of our time commuting. It's been so much more enjoyable, and I have time now to spend with family. And whereas in the past, I did virtually nothing but just work and commute home, perhaps work in the gym, but it was pretty much a very hectic life, and I'm enjoying now replacing some of that with more personal time and time to spend with family.
Okay, wonderful. Well, thank you all. That was, I hope you enjoyed that. I really enjoyed learning a lot about what you've all been doing. It gives us a chance to get to know one another a little bit, even if only virtually. First of all, I want to make sure that you all can hear me well. I know I tend to be a little soft-spoken. Everybody can hear me? Okay. And so what I'm going to do is ask you to mute yourselves for a little bit while I give a bit of a more presentation. And then I'm going to be calling on you throughout the course, either on people I see on my Zoom, some of the names I see on my Zoom, or I may just ask, throw out a question for everybody or anybody to answer. So be prepared. And can you all see my slides? Okay, great. I just want to make sure of that. You see anything other than the slides? No? Just the slides. Perfect. Okay, making sure of that. It's always good to double check that the screen sharing is working well. Okay, so precision medicine is really a game changer for decision making. And I did send around a brief primer, a review paper about precision medicine, hoping that you'll read it in advance. Many of you, of course, already know a lot about precision medicine, which is wonderful. I want to ask how many of you did read it. I've discovered that when I do that with my students in a class using Zoom, it's really interesting experience, right? Because you can immediately see people's eyes kind of looking away and shifting and looking down and all of that. And so the responses in Zoom are really quite different than what you pick up in a on the ground or in-person classroom. And actually, I'm just going to go off on a very brief tangent here because I think it's important. What I've discovered is that this particular element or feature of using Zoom or virtual conferencing, because there's other programs you can use as well, like BlueJeans and others, also makes it a good method for certain types of research, like collecting data from focus groups or doing interviews, that kind of thing. So you pick up some of the facial expressions and that sort of thing actually somewhat more readily than you do sometimes even in person. So it has its pros and its cons, but certainly I'd encourage all of you to experiment with it and try it out if you have an interest in doing so, if you have an interest in collecting data virtually as the pandemic drags on, using Zoom or some other video conferencing tool. Okay, so I'm going to assume then that you have a reasonably good understanding of precision medicine. And what I want to focus on today is really the concept of risk and parsing out that concept. So this is my disclosure slide. So you can see my research program, and my center has been funded by grants from a variety of sources, but I have actually nothing in particular to disclose that's relevant to specifically more or less to this presentation. A little bit later on, I'm going to be speaking about a role-playing game that comes out of or is being funded by a grant from Genome Canada and some other funders as well. So a very large-scale grant that we're doing in collaboration with the Canadian Pharmacogenomics Network for Drug Safety, and the project title is Genomic and Outcomes Data Bank for Pharmacogenomic and Implementation Studies. So I'll be telling you a little bit about that later on. Okay, so what I would like to do now is give you a pop quiz. Actually, what I want to do is, it's not something going to be graded, is just a poll. I want to go into, let me see where the chat went. Okay, chat. And I am sending into the chat, I just sent you a link to SurveyMonkey. And if you could take about 5 minutes or so, probably won't take you even that much, to respond to some questions about risk. So there are about 10 questions, and they have 3 different options, and just pick whichever ones it is. And if you could do that, that would be very, that would be great. And then we're going to pause here for a few minutes and give you a chance to do that, and then we'll come back on and talk about your experience. So I'm going to mute myself for a minute while you do that. So Click on the chat. If for some reason you're not able to do that, let me. Okay. Has everybody completed the survey yet? Yes? Okay. So I'm going to ask you to unmute yourselves and maybe share a little bit about your experience with that. What did you think of it? It's very simple, but, you know, and it's not going to be used for research or anything like that. But I kind of want to get a sense of what your thoughts are very quickly, just whatever comes to top of mind, whatever comes to your head, as to what you thought of some of those questions. Was there any particular question that either surprised you or you thought was, you know, something that you found a little more engaging than other questions, or perhaps more helpful? So, Kate, why don't you start? Why don't you tell me what you're thinking? What your
Scrolling through that a little bit. I thought the public health one was interesting. I'm trying to find it now. I think it was something about like whether public health is about certainty. And I guess I just think that's very domain specific. Like nutrition just seems like a really difficult place to get definitive evidence. And the fact that we keep flip-flopping and saying, you know, eat low fat, eat high fat, eat this, eat that, doesn't seem like a crazy amount of uncertainty to just have to live with. And, but there's other things, you know, like smoking, where it's nice to have a definitive public health message. So yeah, that just felt like it could go in a million different directions.
So very interestingly, I'm looking at the results now, and I can't share them on the screen just because there's just, I don't have the capability to open too many screens, or, you know, I'd have to stop screen sharing, and it technically it becomes a little more challenging. But I can tell you what it said. So 83%, or 83.33% to be exact, of you said that, in fact, this is somewhat characteristic of me. So nobody said it was completely characteristic of them, which was interesting with that question. Anybody else? Would like to share anything in particular about one other thing that I'd share with you is the question related to genetics, which is says it gives me information to reduce uncertainty. I literally got 33, 33, and 33%. I don't know if you can see that, but it says this is what that looks like for genetics, which I thought was rather interesting. Like it literally broke up into thirds. Very interesting with this group that genetics did, the question about genetics did that. So the question is, genetics gives me information to reduce uncertainty. Essentially 2 people said it was characteristic of them. 2 people said it was somewhat characteristic, and another 2 said it's not characteristic of you at all. So it literally broke up into thirds, which is quite interesting. Anybody else want to share something about this little survey? I mean, obviously it's not a very not the best scientific one, but it's just one we're having a little fun with right now.
I would actually say, so the genetics question, the public health question, I was the one person who said that public health is not characteristic of me, just because I feel like both the genetics and public health questions were a little bit vague. So of course I'm asking, well, what do you mean? In what context are you asking? So I think it's how you interpret it. You know, being in the GYN oncology world, we deal with genetics all the time and how we treat patients. So like, you know, I definitely have bias when I answer these questions. And I think the one that I thought was interesting was 9, where you developed, you know, the sort of ratio. You know, with no experience, you know, in decision science, I guess I don't know what is that a valuable ratio. It'd be interesting to see where people decide to make that decision, what the ratio is.
Okay. That's very good. So again, that's another question which says, whenever I think about the risk of doing something, I weigh up the potential rewards and take a risk if the risk to reward ratio is 1 to 3, which risk being 1 and reward being 3, where everybody basically, it broke up into thirds as well, like this, which is kind of cool, rather interesting. So that's another question.
Those were my thoughts too on that question, that it was interesting, that line in the sand of a 3 to 1 odds of reward to risk. And I thought it was, you know, where did that line in the sand come from? Was it just to provide a marker, or, you know, what was the thinking behind that?
So that actually came out of when you speak to people who obviously are not the self-selected audience who are interested in taking a course on, spending their Tuesday afternoon taking a course on decision making. And you're going to see as I get it more into it how people start to think about risk. It's very interesting to see how people do think about risk and risk tolerance, and that's something that I think in this field of decision science and we haven't dealt with a lot. And so I'm sort of getting more and more into it. And I think the world of precision medicine and now the post-pandemic world as well kind of almost really impels us to get into that because people are starting to think about risk a little differently, or at least they're becoming a lot more aware of it. So that actually did come from consumers or patients or whatever we want to call them, who may not be the self-selected group of people that we have on during this class or during this course right now. Really, I just wanted to present that. Again, not going to do anything with these results. It's not a research project. You know, otherwise I would have had to do all the IRB stuff, but just wanted to get a sense from you and to show you kind of how, when you start to poll people and when we start to survey people, how we start to tease out things and how we start to think about things, and how we, as a self-selected audience of decision scientists, think about things differently than other people out there, and knowing that is important for us in terms of engaging, in terms of patient engagement. So anybody else would like to add any other thoughts? Because I'd like to hear your thoughts before we move on. Any other questions or thoughts or things that kind of brought up into your mind? Okay, all right, well, let me see where I was. Here we go. I'm just going to move everyone back to the side here. Here we go. Okay, so so this is an example of articles and blog posts that you see routinely nowadays. Life is now a game of risk. Okay, so, and this comes from this Medium, basically, which is one of those blog posts. Except I would really beg to differ with that. I think life has always been a game of risk. It's just that how people now have a heightened sense of risk, and they're thinking about it a lot more in terms of our day-to-day lives. And I think what's changed is that we simply did not think often about things like the risks of getting hit by a car or the risks of not getting a flu shot, which are actually fairly high depending upon how you look at it. And so what I want to do today is I want to focus our discussion on risk, and in particular walk you through some concepts and nuances that are a bit different than what you might be used to hearing and thinking about risk and healthcare, and certainly in the precision medicine world. And because we're all living and working in healthcare during a pandemic, we can't really ignore it. I think it's particularly important to think about risk and try to parse it out a bit more granularly. Okay, so I want to orient our discussion today around 3 questions. How has our willingness to assume risk changed? How are patients incorporating risk into their decision-making now? And what does this mean for our healthcare providers and for decision scientists? So one of the hidden tragedies of the COVID-19 pandemic is the degree to which people have put off treatments for serious health conditions, in many cases avoiding even urgent medical care over fears of catching the new coronavirus. And, whoops. So, they're afraid to visit a healthcare clinic during the pandemic, so they just keep putting off going to get whatever healthcare they need, and they often arrive at health systems sicker and sicker with more advanced illnesses than they otherwise would have had if they had sought care earlier. So, how are people now weighing different risks? Well, we know that 6 in 10 Americans have 1 or more chronic diseases. So we know that this is a problem, and that these diseases didn't just go away when the pandemic hit. So that this is a consideration. No, this is one of many surveys done over the last few weeks and months, and this one is from the Kaiser Foundation, and certainly you could have picked others, but this one I think shows this quite nicely in a graphic format, and shows that 48% of the American public said they skipped or delayed getting care because of the pandemic. And this has been well documented. This is from the New England Journal of Medicine. I don't know if you've read it. It's a fairly good editorial to read, good article. And in addition to their fears and concerns about the coronavirus leading them to delay seeking care, so the idea that people are concerned about themselves catching the coronavirus, patients and the public are also very much aware of the risks associated with taxing the healthcare system and healthcare providers. And part of that is because we've basically trained them that way. So throughout the pandemic, we've all seen messages like this headline. This one just happens to be from the Washington Post, but you can pretty much pick up any newspaper or go online anywhere from anywhere in the world, literally, and news outlets anywhere in the world. And everything, pretty much every place, every country certainly has carried a similar headline or a similar message. COVID-19 hits doctors, nurses, EMTs, others threatening the health system. There's also thousands and thousands of messages on social media, whether that's Facebook or Twitter or Instagram or Snapchat or however you consume social media. And I just want to point out a couple of these. I somewhat randomly picked them out, but I also picked up ones that were put out by healthcare providers simply because there's a couple in particular that sort of dramatically make the case. So this one's from Craig Spencer. I don't know him personally, but he is an MD, MPH, and he talks about having survived Ebola and fearing COVID-19, and tells people, do your part, stay home, stay safe, and every day I'll come to work for you. Okay, so that line at the end of that, I suppose this is Twitter, it is quite interesting and telling in terms of the message it sends people about risk and who's assuming risk. Here's another one. Rachel Potzer, PhD. Again, I don't know any of these individuals. My spouse is a physician in the emergency department and is actively treating coronavirus patients. We just made the difficult decision for him to isolate and move into our garage apartment for the foreseeable future as he continues to treat patients. We have a 3-week-old newborn and 2 young kids and just can't risk it. It pains me to wonder how many weeks will go by that he won't get to hold our new baby or see our older kids. This is one example of the sacrifice that healthcare workers are making for our communities. And all of these communications are well-intentioned, telling people to stay home so we can flatten the curve. And in some places that I've read about, they actually talked about plummeting the curve. But one unintended consequence of all of this well-meaning communication, it turns out, is that many in the public are now assuming this risk onto themselves. And so this, of course, is something that was not foreseen. And again, to use a word that's been overused, unprecedented. In healthcare, we're not used to asking the public to collectively take care of us or think about the risks to healthcare providers and the health system. So this is a phenomenon that is quite new, and I would say that's one worth exploring for and thinking about in terms of how we engage patients in decision making. Because I suspect that thinking about risk in this way, this idea of what we're asking people, even unconsciously or subconsciously, in terms of assuming risk, is something we'll have to contend with in a way that we may never have before. And I don't think we're going to be able to go back. So let me introduce you to this new concept, or at least it's new to our field. It's one that we don't typically think of in terms of relationships in healthcare between providers and patients, and it's this idea of risk transfer and risk sharing in healthcare. Now, this is something that is quite common in, say, the health insurance industry. If we were to stop and think about it for a moment, we see that there are lots of areas in life where we have willingly assumed more and more risks over the last several decades. For example, we all, to varying degrees, have personal data out in cyberspace, right? We do our banking online, we make purchases on Amazon, we buy groceries. Some people buy yarn at Etsy or whatever else they do at Etsy. And from time to time, we receive notifications from an organization, an institution, telling us that there has been yet again another data breach. And some of the organization's customer information, possibly ours included, may have been compromised. And most of us can't do very much about that. We may rant and rave or be upset for a little bit, but really we can't do very much about it. And we know that when we signed on with that organization and agreed to and accepted the terms, whether we actually agreed, bothered to read the fine print, and we know that most of us don't do that, we assume that particular risk, that somehow there would be a compromise in some of our personal data. So we've been assuming more and more risks that were traditionally the purview of governments and corporations. And now it seems that we are having risks transferred onto us in healthcare as well. And we see this, of course, like I said, in the area of health insurance, where individuals are bearing more and more of the costs of health insurance each year. But now I think we're beginning to see this happen in areas more directly relevant to direct patient care as well. And to some degree, this can be somewhat good in some ways if you think about behavioral interventions from a public health perspective. But we have to be careful because we do want to ask the question, what is the right balance between that and asking patients to shoulder risks and decide such things as whether health systems are prepared to take care of us in the midst, or them in the midst of a pandemic. So I wanted to introduce that idea to you, this idea of the great risk transfer or the great risk handoff, and discuss it as kind of the backdrop of a newish research agenda, which involves parsing out more components of risk at a more granular level. Before I move forward with that, let me stop for a minute and ask you if any of you have noticed this phenomenon and what are your thoughts so far on that. So I'm going to pause and ask you to share some of your thoughts. And I can call on people, or better yet, somebody can volunteer, please. Randy, since you're the physician in the room, the pediatrician in particular, perhaps you might want to give us some of your thoughts on this. I don't know I know if you've noticed this kind of thing happening. I know it's fairly new in terms of what we're thinking about, but I don't think it's only specific to what's happening with COVID-19. I think it's something that's been kind of slowly, imperceptibly happening as, you know, over the last several years. So what are some of your thoughts? Can you let us know?
Yeah, I think as you were talking about this, I was just considering the different people that I've interacted with and how, you know, risk for one group gets assumed by another, or a piece of risk information that applies to a certain group is generalized to a population or to another group or something. And I mean, my primary thought is, yeah, I agree. I mean, as risk information becomes more available and data and information are more readily shared, and that data information have the perception of being accurate with numbers attached to it, with some type of risk number, and people, I think, may be more willing to believe it and share it and accept it into and embrace it into their own lives and thinking, because it gives this sense of something concrete and something that they can kind of base their decision off. Kind of, you know, the survey we just did of, you know, that decision and uncertainty. Well, here is something, you know, solid we can go off of, even if it may not be correct, or it may be kind of usurped from a population or a group that does have the risk, you know, inappropriately transferred over. But I agree that is happening. I don't know that it's I mean, I think it's probably increased over the past, you know, in the pandemic, but I think it's probably a phenomenon generally of, in healthcare at least, of us having more information, more predictive models that output some type of number that we want to be able to rely on, as opposed to some vague narrative description of risk.
Thank you. You want to call on anyone else to join in our discussion? So I don't have to do it all the time.
Anybody? I have no preference.
Anybody you like. You're seeing a screen as well.
Let's see. The name Lauren.
Hi.
Tag, you're it.
So I haven't, I mean, I guess I hadn't thought of it before, but I guess what you had referenced with the Twitter and, you know, kind of having then, you know, the public assume that risk, I think I felt that early on. You know, I'm not a clinician. So I guess, you know, just in this discussion, I don't think I have much to add necessarily, except that I see what you're saying. And you know, I think I feel that, especially at least in the time of COVID. You know, and I think maybe too, it is either, yeah, right, depending on what you're hearing or just, you know, from the, whether it is the media or even physicians, you know, trying to stay home or, you know, trying to be safe, and otherwise there is this unassumed or, you know, potential for risk. So kind of maybe, yeah, putting it more on us to do our part. And
so let me ask this, and Lauren can answer, or someone else if you really don't want to, but how do you see something like this, so that so I don't bias you too much? How do you see something like this actually becoming integral to, or an important component of decision-making and decision-making science and research that we're all involved in? Because all of you are involved in different aspects, and you have an interest in decision-making and engaging patients and engaging other providers. And I guess some of you are more involved in aspects of research more than others. And I've heard from, you know, all of you, particularly those who might be doing some HEOR work as well as others. So let me put that question out there for all of you. How, and Lauren, you can start, or you can decide to, you know, call on someone else to be it, to tag somebody else. But how do you all see that changing the landscape of decision-making and decision sciences?
so we actually we're doing a study right now on colon cancer screening for patients who were due or overdue. So we've been surveying patients who, you know, had missed their cancer screening for this past year. And we've actually assessing risk. So that's one of the questions, you know, trying to assess their risk perception for sure. So we're surveying that as well currently. So it is interesting, and at least definitely to include, to get a better understanding of how patients are considering, you know, their healthcare and their screening and kind of things that they should be doing compared to what risk they perceive, you know, whether it's the hospital or transportation or, so it is definitely something that, you know, so I'm interested in, and we are actively researching too here at Mass General. But I do believe, certainly, yeah, there are patients, you know, who certainly have, you know, a risk perception, thinking the hospital's unsafe. And so I think the hospital's trying to do their part, like recently, new marketing. And I think that that's what they've been all gathering recently, trying to promote to patients, the hospital is safe, we're doing our part, you know, and just trying to make patients feel safe, and trying to get them back in for the care.
Great, thanks.
I'd actually say so. As you know, I work in oncology, so it's very interesting because like a majority of how we treat GYN cancers is we operate, and so it's crazy to see how both in residency now fellowship, I see how patients have even changed their decisions about. It's very important once you're a survivor in GYN cancer that you follow up for screening, and some patients have deferred, and we're kind of trying to figure out how can we do telemedicine with patients who are scared to come into the hospital, because, you know, an essential part of a GYN exam is doing the exam, so you can't supplement that via telemedicine. And then even just with patients thinking about their decisions, I've seen patients for cancer surgery actually try to go for chemotherapy instead of frontline surgery, which is the preferred route, because they don't want to be in the hospital for 5 days and nobody can visit them. And so it's really difficult for them to recover. And there's so many different aspects of their decision making and thinking about the risks of COVID, you know, people not coming into the ED and then they have traumatic events at home. It's, you know, it's very interesting seeing how patients have really thought about that risk.
I just wanted to make a comment as well that it seems as though risk in itself can be very complicated and personalized and different for every individual, because there's an overlay of that individual's value of whatever is at risk, and that might be different. So it becomes much more complicated. It's not just a black and white, you know, sort of quantitative decision. It also has patient preferences, their perceived risk, you know, and so there's that sort of behavioral overlay over something that, you know, we would want to try to quantify, but it, you know, there are a lot more complicated factors to consider in any decision.
Good point. Okay, Kristalia, would you like to add anything? Or Kate?
I guess I can add a couple of things. So a couple of things that are happening at Foundation Medicine are a couple months ago, we got FDA approval for a liquid CDX test, and we've been doing a sort of a solid biopsy test. And so that's been a really interesting conversation in the context of COVID, you know, because the liquid information is great, but it's not exactly perfectly concordant with the solid test. But you can send phlebotomists out into the field, and there's just a much different, there's an information trade-off in sort of the ease of collecting that information for the patient with sort of the potential noise or differences in quality of those tests. So that's just something that we're trying to figure out, is like how to optimally deploy these different tests based on sort of the, you know, current situation, and then long-term figuring out when it makes sense to do sort of what we're calling like a liquid first approach versus sort of the standard solid tumor biopsy test. And then in terms of like what you were talking about before, we have this crazy, you know, data set with all of these genomic results and patient outcomes linked to the Flatiron EHR system. And, you know, we're starting to think about how to deploy sort of algorithms to help guide treatment decision-making. But something I've been thinking about in that is, you know, how is that shifting the risk of sort of medical practice in sort of these development of algorithms away from the individual clinician to, you know, whoever is creating the algorithm that's trying to automate those decisions. So those are just some of the things we're thinking about right now.
That's actually a great question. Yeah. And Anne, I wonder if you have anything to add to that, since you're doing a fair bit of work related to AI and algorithms with respect to decision making.
I think one of the things that we're grappling with is especially in the cancer area, is that everything is so complex. There is difficulty in being able to sort of drill down and quantify all of the mechanisms that are going on, and including adding you know, sort of a precision science and precision medicine approach to things. It's then having to back up from that and realize that there is so much that is unknown yet. We haven't figured out, you know, the complexity of how genetics plays in. We haven't figured out, you know, all of the socioeconomic and, you know, attendant factors that weigh into risk. And so trying to solution through big data or through artificial intelligence, and solutions like that have been fraught with difficulty in being able to come up with those types of solutions. We would hope that by this time there would have been enough technology developed to be able to come up with data-driven solutions, but we're finding it's still very difficult technically to implement those kinds of things successfully.
Do you agree with Kate, but what she was saying about, because I think she made a very interesting point about how algorithm developers and the people who are actually developing some of these technical solutions or technical, some of the technologies are maybe assuming more of the risk. And it's sort of an open question out there as to how much risk they're assuming in terms of when they provide that information to patients and what that means, right?
Yeah, and that's the other issue that we're grappling with as well is how do you build, you know, a quality sort of technology that, you know, has a proven bound of, you know, sort of acceptability, and in terms of coming up with the accurate, you know, recommendations, for example. So the developers try to, you know, sort of quantify the risk involved in any decision that's made, but it's a very, it is walking a tightrope. It's very hard to come up with an algorithm that is able to sort of transparently also show you that there is a large, you know, sort of variation on, you know, each decision that's made. It depends on, you know, perhaps thousands of factors. And it could be that half of those factors, we don't know how they affect the decision. So it is, it's a very difficult undertaking, and I do, you know, sympathize with all of the developers. And how do you then develop something that is helpful, and at the same time lets people know that it may not be perfect in every situation.
Yeah, and I'll just add to that, like it's very interesting. So I'm you know, I've worked at Foundation Medicine for only a few months, just graduated. My PhD dissertation focused on value of information, which is all about, you know, uncertainty, and sort of where I'm at least trying to head first is really understanding we can both, the information we provide as a company to patients and oncologists can reduce uncertainty and say, for sure you should be doing this, for sure you shouldn't be doing that. But it can also inflate uncertainty and say, oh, there's all these extra things that weren't a possibility before you got this information. And I think what I'm interested in is characterizing when that's upside uncertainty versus downside uncertainty. Because those are very different things to introduce into a patient and oncologist decision-making process.
Okay, thanks very much. And I've noticed that we have another person who's joined us, Kristin Mackey. If you'd like to very briefly introduce yourself, just tell us your name, and first, I hope I'm pronouncing it correctly, and what organization you're with, what your role is. And we're talking about risk and the idea of a risk transfer or a handoff, as I call it, within, you know, the last few years, really due to precision medicine, due to the pandemic, and other considerations in healthcare. So Kristin, if you would just introduce yourself and welcome.
Thank you. So like you said, my name is Kristin Mackey. I am a postdoc at MD Anderson Cancer Center in Houston. My background is in health communication, so my dissertation work was actually looking at persuasive effects related to different message types. So I'm in decision science now, which is a nice extension of that. And I'm interested in looking at precision medicine in terms of how we can integrate some like personalized risk information into decision aids. So that is kind of where my research is heading toward.
Oh, terrific. Okay. So I actually spent a number of years in Houston. I was at the University of Houston School of Pharmacy, but also have a number of collaborators and at MD Anderson. So great. Not sure what the weather's like now, but I do remember, the one thing, I miss Houston in terms of many of the people and the friends I made and the collaborators, because Texas Medical Center is a terrific place to work, but I don't miss the weather, that's for sure.
That is very accurate. We do not have leaves like your background.
Very good. Well, welcome. Let me continue on now that we have had a good discussion, and then again we'll make periodic pauses to be able to continue this discussion. But this is really very helpful because, as I said, this is sort of some new concepts and new emerging areas of research that I've been thinking of and developing with my team. And so it's really great to be able to have these discussions with all of you and to kind of pick your brain a little bit and to really help us all think through some of these issues in decision science. So if you read through the materials that I sent or emailed to you, and I'm sure, of course, and having heard what your backgrounds are now, you all know a lot about precision medicine. So I'm glad I made the right decision not to include a lot of slides giving a background information about precision medicine, and so I won't bore you to tears. But I'm sure that you know by now that what precision medicine does and what genomics does is it really adds nuances and complexity to the types of decisions that we encounter, and as a consequence to how we engage patients and providers. And we're going to be speaking about a few of those types of decisions in a minute or two. But to fully appreciate that, let's just take a moment to remind ourselves really of the basics for a second. Decision-making generally happens under one of three conditions: under certainty, under risk, and under uncertainty. So this is what it looks like when you have a good deal of certainty. This is what making a decision with certainty looks like, right? It's a little bit of a simplification, but it makes the point. You look at the sign and you head towards your destination. You know which way you're going. On the other hand, this hiking trail, which is quite beautiful, represents what it's like to make a decision under uncertainty. There are no signs or markers, and I really don't know which way I should go. And other than the joy of exploration and the new beauty of nature, this is pretty much a representation of what uncertainty, making a decision under uncertainty looks like. I don't necessarily have a good clue as to which of these directions I should go in. Decision making under risk is a matter of probabilities for the most part. And since you're all a self-selected audience, I'm going to assume that you have some idea of what understanding probabilities is like. And this schematic really is an oversimplification, but it basically makes the point really that you have in this concept, or it kind of explains the concept. You have two options in this case, and you're faced with the probabilities of certain outcomes. Outcome A1, outcome A2, or in case outcome B.1 or B2, right? So you have, and it gives you what is whether a particular outcome is going to happen or not and here they're expressed as percentages. Of course, when we are given information on probabilities, it's almost always population level statistics and information. And that's really one of the problems of presenting probabilities, particularly to patients, but it's not the only one. This is, okay, so before I go there, let me take another very quick break and ask if there's other issues when you present. What are some of the issues when you present questions or present probabilities to patients, whether you do so in a research environment or in a clinical environment that you've encountered? Obviously, this is one of the problems, but what are some of the issues?
I think definitely one of the issues is whether or not they want to hear probabilities. You know, oftentimes when we talk about prognosis with our cancer patients, we ask them like, how much do you want to know? And then they oftentimes, you know, there's been some trials in oncology that there's studies that show that, for instance, patients would prefer individualized statistics rather than broad everybody in their shoes types of statistics. So it's hard to kind of tell what patients want.
Okay. Anybody else want to add to that? Any other issues that you've come across, or even solutions, things that you found helpful that work in terms of presenting probabilities to patients, whether you're doing it again in the context of a research study, which many of us do, clinical research, or in the context of actually engaging patients who have cancer or some other disease, or and a particular prognosis, or diagnostics, whichever. Anybody want to share some of that?
We do a lot with, you know, decision aid implementation, and so in the decision aids themselves, we'll provide 100 people plots, and so trying to show risk, you know, complication of a surgery, or, you know, or benefit of this treatment. We often try to show it visually for patients. I think Sarah was saying, you know, some patients are different; they want to hear it or they don't, or they have certain literacy to understanding it. So trying to visually show it, and also using whole numbers, so 1 in 100, and being consistent, you know, with the way that you provide the information, we found has been useful for patients.
Okay.
In contrast to what Sarah had said, in her practice, for me, it's you know, I'm not dealing with you know, life or death, you know, cancer prognoses or things, but one of the obstacles has been the preconceived risk, or the, you know, their prior belief of risk and willingness to accept the actual risk. I'm thinking of vaccines and immunizations, where, you know, there's a risk of things like, you know, something that is 0% in the vaccine, but nonetheless, there's a belief that it's there, or some, you know, some very, very rare outcome is held to be, you know, either valued too much, or just, you know, a misunderstanding the risk of it. And then to what Lauren's point had said, I'm also working on with a study that is doing colorectal cancer screening, and the PI is of the opinion that the actual risk numbers should not be provided. And so we are implementing a decision support that categorizes people into a low, medium, high type of, you know, more of a categorical type of risk, and assessing people's behavior based on that. And so sometimes, you know, people just want to know a broad strokes relative risk as opposed to an absolute, you know, percentage, and that may go into their risk literacy also.
Great. Well, thank you for all for that. That's very helpful. And you'll be pleased to know, if you stay tuned, I'm going to share with you some really interesting and exciting information. Not so much data, but just kind of some information a little bit later on when we talk about this role-playing game, this innovative role-playing game, because it really does sort of get at the heart a little bit more. Although it doesn't address risk per se, it does address health-related quality of life issues, and in pediatrics, in pediatric context. And so it'll be very interesting, I think, for you, Randy in particular, but for everyone really, to kind of see a different way of assessing kind of what patients want and how they engage with information. So, all right, is there anything else anybody wants to add or any other questions anybody has? Okay, if not, I'm going to, let me just, okay. I will keep moving right along. So here's an example from some focus groups with different populations of cancer patients that my center did a while ago. And we have a lot of quantitative evidence as well. Also, we do quite a bit of work measuring trade-offs that patients make as well as other data. But I think this particular qualitative data here really presents us with how challenging this problem is. And that's why I particularly selected this, this one piece of data to show you. So, you know, you've got here's a colon cancer patient from one particular group saying, for genetic testing, I worry a lot about accuracy because I didn't have it I didn't get accuracy on what I had, which surprised me. And on something that affects care like genetic testing does, it's hard for me to accept that they would do one test and they wouldn't have proper controls. So this person was speaking about a very specific situation that he faced, but it does still give you some idea of some ways that patients think about things. Here's another one from a breast cancer patient, which is also speaks to the whole concept, I think, of risk and risk tolerance in particular. If it were 98% accurate, I wouldn't need a confirmation. If it were just 90%, I'd need a second test for confirmation. So some of the things that you were talking about in terms of you know, risk literacy, people not really, you know, people don't really have a concept of things like specificity and sensitivity in tests when we do testing, genetic or otherwise, which, you know, honestly, there's even some healthcare providers who don't have a really good grasp of that, right? And so this is one of the challenges that we all have to deal with in this field. One of the things that we've looked at with various folks has to do with this notion of prevalence and penetrance of genetic variants, and which is very much integral to genomics and precision medicine. So how people understand prevalence versus penetrance of genetic variants is really a major issue in terms of how they understand risk. So we know that we get results returned that have low penetrance. They are common variants, but have small genetic effects that don't contribute much to disease susceptibility, for example. However, this does become an issue when patients, or in some cases, consumers of online genetic testing are provided with results. Okay, so that's just showing you that. And this is an example of genetic variants. It happens to be about breast cancer. And as you can see, just from looking at this, you know, penetrance about 40 to 90% lifetime risk, you know, for some of these BRCA1, BRCA2, TP53, some of these other ones. And then again, odds ratios, if you look at the odds ratio at the bottom there, which is fairly small, 0.75 to 1.25. And then the prevalence in a general population showing 1 to 50%. So this kind of information, you can see how it can lead to ambiguity, even among healthcare providers, let alone patients. So we do really have our work cut out for us when we're trying to understand risk. So these are a couple of quotes from an older article by Thomas Getz, who's the former editor of Wired magazine. And I selected these and I like them because they express a sentiment that I hear frequently from patients. Now, he was speaking in particular about direct-to-consumer type of genetic tests. This is what that article was about. But I still think that even in the healthcare setting, we do kind of run into some of this. I think it's more striking in the direct-to-consumer world, but you know, before we pat ourselves on the back, we have to understand that these kinds of sentiments are also valid to some degree even in our more carefully controlled clinical environments. So, you know, it talks about company A. You notice when you get your results is how subtle the differences are between the average person's risk for disease and your own. For colorectal cancer, for instance, my results tell me that I have a 0.21 out of 100 chance of developing the disease compared to 0.26 out of 100 average risk. That may be scientifically valid distinction, but as a consumer, it's so slight as to be of no difference. So one of the things he did was he actually had looked at different companies, sent out saliva samples to different companies to try and see what kind of information he got back. So it was kind of a bit of an experiment on his part as a journalist. Company B uses a different method of calculating your genetic risk. It generates a lifetime risk analysis that results in what the company believes are stronger calls. Certainly the numbers seem more emphatic. Examples I saw showed, for instance, a person with a 51% risk of heart disease compared to an average 42% risk. That's a striking difference. So this idea of how we present risk to people and what that means, again, is very important. Now, this is not new information to any of you, but I did want to put it out there. Basically, the precision medicine, artificial intelligence, big data revolution, all of that has really shaken the stability of the healthcare environment, causing the conditions of even seemingly routine decision-making to change from certainty to uncertainty. And I think the ongoing pandemic has dramatically made that more so. And I think it's very important, as I was saying earlier, that we all should be thinking about what risk means and how our patients are now perceiving risk and their levels of tolerance for risk. So, okay, so before I get to this, first, does anybody need a break? Because we're at the point where we could use it. If anybody wants to take a break, we can certainly take a 5 or 10 minute break. Because I can also keep going for a little bit longer and then give you a break in about 10 or 15 minutes. I'm going to take a vote. Who would like to take
taking a break in a few minutes.
Okay, anybody else? You all agree, in agreement? Okay, if you're all in agreement with that, let's do that. All right. Thank you, Randy. Thank you, everyone. Okay, so given all of these issues, what I'd like to introduce you to now are some concepts that I've borrowed a little bit shamelessly from actuarial science. And I'm applying them to healthcare and particularly to precision medicine. I haven't seen anyone else in the literature do this. So I think we are doing something quite original. But I'm doing this because I believe that we are really at an inflection point where our understanding of risk is beginning to shift, just as I was showing you earlier on, and new developments in how we understand and engage with risk and engage other people in their understanding of risk are really quite needed. So in healthcare, we're used to talking about concepts like risk-benefit analysis of treatments when making decisions, particularly, for example, when we're talking about shared decision-making, and when we're developing decision aids, as some of you are. And there's also some work and literature on preferences for risk, and that's out there. But I think risk is really a more nuanced concept. And I think it's important because of the disruption to healthcare that we are experiencing right now, where we really need to start parsing out some of the risk into its different components. So let me introduce you to 3 new concepts that my team and I are now playing with in the realm of precision medicine decision making. Put simply, risk appetite is the general level of risk that a company or in the case I'm thinking of it, an individual accepts while pursuing their objectives before deciding to take any action to reduce that risk. The second concept, risk tolerance, on the other hand, is the degree of variance from its risk appetite, meaning the degree of variance from risk appetite that either a company or an individual is willing to assume or willing to tolerate. So if you think about something we're all familiar with, speed on a highway or freeway. And it's sort of I think it's a fairly good analogy of kind of explaining the difference between risk appetite and risk tolerance. State departments of transportation set a speed limit for, let's say, a major highway, okay? This can be considered comparable to risk appetite and indicates what the state departments, administration or executives believe is an appropriate balance between traffic flow, on the highway, environmental wear and tear, and public safety, among other things. So typically drivers will try, when you're driving along that highway, so let's say it's 60 miles an hour, okay, or 65 miles an hour. When you're driving along, you're going to travel at either a little bit higher or a bit lower than that actual speed limit, rather than exactly at the speed limit, right? Very few people actually set their dial on cruise control for 65 miles an hour or whatever the speed limit is. And the point at which law enforcement starts to ticket speeders, people who are speeding, that can be viewed as analogous to risk tolerance, okay? So given normal weather conditions, okay, law enforcement officials rarely enforce the speed exactly at the limit. So risk appetite is the actual speed limit that has been set, and you know, this is the line in the sand, if you will. But law enforcement, you know, the police, the state, whether the state police or the whatever police they are, don't actually enforce the speed exactly at the speed limit. They usually tolerate a certain amount of risk, okay, given what the weather's like, okay, and so you know, and some other conditions as well, right? So risk appetite can be considered that line that's drawn in the sand that helps to set the expectation, 65 miles an hour. Okay, risk tolerance, on the other hand, can be viewed as the variation or the variance from appetite that drives the day-to-day decisions to operate differently in some way. Okay, so does that make sense? That's kind of how I'm thinking about it to try and explain it. Okay, and I think the same thing happens whether we're aware of it or not in terms of decision making for healthcare and for a variety of health decisions, particularly when we're thinking about precision medicine and some of these other decisions that some of the newer technologies have brought on us. And so the risk threshold then is basically kind of the sum of these two other components, risk appetite and risk tolerance. So we've incorporated into our research programs and kind of a new arm of our research agenda that is focused on better understanding risk in the patient journey as a continuum, so that we can ultimately better help patients and consumers as well as healthcare professionals in managing or trying to better cope with and manage risk. So trying to kind of look at risk in a kind of a different way than what we're used to in the world of decision science. So we are in the process of developing an instrument, a tool to measure risk tolerance under different conditions, and also using scenarios and vignettes to gauge risk appetite with the aim to quantify risk thresholds under varying conditions. And this is our first product, a mapping out of risk tolerance. It's a bit of a crude map, if you will. But it's, I call it the risk awareness and tolerance, or RAT decision tree. You know, in academics, we always have to come up with acronyms. So I call it the RAT decision tree. And so basically, what we want to be able to do is to measure how people evaluate different risks, whether they recognize the pitfalls, so the cognitive biases that they might have, their awareness, so to speak, and how they think through the actual risk, and then what is the tolerance for a given risk. So we have, you know, detecting the potential pitfalls or biases and being able to name it. In so many cases, we're not able to recognize that, and they engage in risk, in behavior that carries some risk without understanding the consequences, right? What that actually means. Then we have here on this decision tree assessing the risk. Do I actually understand the risk? Being able to get at that. You know, whether the pitfall may or may not be understood. What are the gaps in knowledge? Uncertainty. Is peer influence involved in this particular situation or assessment of risk? And then at the level of the decision actually being made, am I judging this to be a low, medium, or high risk for me? Do I accept and tolerate this risk? Well, if the risk is accepted and tolerated, or in another situation, or the risk may be considered too high and therefore not tolerated. So that's kind of basically the concept. It's a work in progress, but this is where we're at with it. And what we'd like to do ultimately is to be able to, as I say, we're developing these tools to be able to measure and get results that might look something like this, a heat map of sorts, where we can visualize risk appetite and risk tolerance. So the ability to take the risk as well as the willingness to take the risk using a number of scenarios and vignettes. And then we can hopefully come up with some way to help score risk tolerance and risk appetite, and of course a risk threshold based on that. And just to give you some of the scenarios we're thinking of in terms of risk appetite and risk tolerance, what is people's risk tolerance for a coronavirus vaccine? Of course, mask wearing. Genetic results with specific odds ratios and interpretation of risk for, say, an example of breast cancer recurrence or some another type of cancer. And then as sort of a quality control scenarios, we want to be able to include otherwise that people might normally do in daily life. So skiing down a mountain, people don't usually think about how risky that might actually be, right? Many of us do ski and do, depending on where you live, perhaps not in Houston, but in other parts of, in other areas. But we don't think about the risk of, say, an avalanche might happen or might not happen. Many people who are good swimmers have, find it quite fun to dive and go diving. There are people who do wall climbing. Sometimes it's indoor wall climbing, which is of course a lot less risky, but there are people who also do climbing along a mountain. And of course, probably a risk that, if we're honest with ourselves, we have to admit many of us have done at least once, which is the texting while driving, right? And that of course is a fairly high risk. We'll stop and think about it, but many of us tolerate it anyway. And then I found this kind of last night, and I thought this was, some of us can relate to this. Sometimes men engage in risky behavior, like when they buy a vacuum cleaner for their wife for her birthday present. That's not the type of risk we're measuring. Anyway, so just that's kind of where we're at, and I'm going to open it up in a few minutes to having a discussion about this and what you think about this concept and this way I'm thinking about things. But to kind of give you a sort of a few key takeaways, precision medicine is here to stay with all its benefits and complexities, including decision-making complexities. Black swans, such as a global pandemic, will happen too, and will also continue to disrupt healthcare. Patient-centered healthcare needs to continue to evolve, and all of us really have to get used to working with constant change, disruptive trends, and new trends that will make the way we do research, clinical care, and interacting with patients continually and dynamically and evolving endeavor. And for that, I think we need to continue to think about and develop new tools and approaches and methods for what we're doing. I am going to, so this is, I always like to thank my team at the center and the funders and patients and providers who participate in our studies. I do have another thing to share with you, which has to do with the role-playing game, innovative role-playing game. But I wanted to put that slide in because I have had a tendency in the past to forget it, so it's there. What I want to give us an opportunity to respond and react to some of what I've presented on risk, because after the break, we're going to shift to a completely different set of, just a different way, another innovative approach, something else, which is the role-playing game. But I want us to kind of give us an opportunity to think through and to discuss and react and respond to what I've just presented. So I'm going to mute myself and open it up to who. should I call on someone? Sarah? You just happen to be the person next to me in the screen, so.
I guess I don't really know much. I don't really have much to say.
I can comment here.
Okay.
These are new. They seem like new terms or kind of new concepts to understand with the risk appetite and tolerance and I'm forgetting the other one, tolerance and threshold, I think.
Right.
Or at least presented in, formalized, presented here. I think I'll have to digest those more. It made me think about the risk literacy, and I've done a little work with the a risk literacy scale, I think the Berlin scale, and seeing how patients or clinicians or anybody, I guess, you're mentioning people in everyday life with risk, how what their risk literacy is as they, are trying to, as you're trying to determine their risk tolerance and, how that plays in it, whether or not you use numbers, does risk literacy matter as much when you're doing, comparative or relative just narrative descriptions, and how does that, how does that affect the accuracy of determining a risk tolerance across people?
That's very helpful. That's good to know. Do you feel, Randy, that these are good concepts to work with? I mean, what are your thoughts on some of this?
They have face validity, given that I've been exposed for 15 minutes to them.
Okay.
So I can say that I think I'd probably have to ponder and kind of chew on them a little bit more to comment more on them, but face validity, yes.
All right, thank you. I appreciate that. I understand what you're saying. Yeah, it does take a little time to think about some things. Yeah. Anyone else? Help us? Yeah, Kate.
Yeah, so I used to teach a short course here at SMDM called Decision Theory Demystified. And one section of that was on risk postures. And sort of like a fun side note in that I built up using utility functions to the Arrow-Pratt risk aversion measure. And then I introduced like these really just sort of funnily called measures that were developed by a Mormon. So they're grounded in sort of these religious undertones. So there's a measure called prudence, which is the second derivative of the utility measure over the first derivative of the utility. And there's temperance, which is the third derivative over, sorry, I pulled up my slides. It's the fourth derivative over the third derivative. And then there's something called boldness, which is the utility derivative over the utility at a particular measure minus the utility at a value of 0. And then there's fear of ruin, which is the inverse of boldness.
Wow.
And so I would just say, like, from my perspective, it would be interesting to try to link these conceptually back to these decision theory measures that are grounded in like the mathematics of utility functions.
I'd love to talk to you some more later on offline about some of this. That's very interesting. Yeah.
Yeah.
I'd like to learn more about. I'd like to learn more about that.
It sounds like you're getting
like
ideas.
Yeah. Well, we definitely want to quantify it more, but like I said, we're fairly early on in this process. So, that's great though. I'd like to hear more about it at some point. Yeah, that'd be great. That's very interesting. Does anybody else like to add anything in particular, or if you have any questions too? That's the other thing. I haven't heard from let's see, Cindy or Kristin Mackey or Kristalia. Let's see if we can bring you into the conversation. Any one of you. Kristalia? Or is it really getting really late in the Netherlands right now?
Sorry, I couldn't unmute myself. Yeah, it is. But no, I'm hearing with interesting. It's an interesting conversation. I don't have something to add. I just following the approach and the presentation.
Okay. You have any questions or anything else?
Not at this point.
Okay.
So I am curious where you would use, say, the heat map with the risk appetite. I really like that idea, and it's something that I've thought of previously, is kind of asking people how much risk they would like to take, kind of using the health minimizer maximizer type of model for what type of care they would like. Where would be a good place of using that? Would it be kind of like at the beginning of a patient-provider conversation, or where would be a good place of?
That's a great question. I do think that yes, at the beginning of having a conversation at some point. I mean, it depends, of course, on the relationship and what is the situation we're talking about. But certainly early on when you're before we're speaking about very specific concrete decisions, trying to gauge a little bit more people's risk appetites and risk tolerances. And sort of get a sense of that and measure it, that would be the ideal, I think, because then it'll help us develop tools or at least tailor the conversation for having a sense of how, what is someone's risk tolerance, and it will change from situation to situation as well as person to person, right? Because I think if we even think about our own experiences, we'll see that, it may be that, and this is just anecdotal evidence, okay, so this is not something I've measured or done any kind of study on, but if you talk to your friends and neighbors and family, extended family members, even people who do all sorts of things that might be that some people might consider risky in daily life, whether that's skiing off alpine skiing off the top of a mountain without thinking about the risk of avalanches, or even doing roller coaster rides at an amusement park, which isn't necessarily terribly risky, but something I've always been a little queasy about. Nothing I've particularly enjoyed. People who might take those kinds of risks without giving it a second thought, some of them are much more risk averse when it comes to the variety of options that seem to be available when you think about, say, coronavirus right now, right? So, and that's not to downplay that it's obviously it really does have something that has real risk. But if you look at the spectrum of how people are dealing with it, there are people who, as much as possible, I'm not going to leave the house. I'm going to order groceries online. I'm going to not worry about, going out for, I don't know, going out to the park because I don't want to expose myself to anyone else if I don't have to. I'm not going to socialize, all of those things. So it isn't just, so there's that end of the spectrum, right? Other than and then there's people who are sort of in the middle who are doing certain activities, but wearing masks and social distancing and all of that. And then there's the other people who are completely off the other end of the spectrum where, no mask, no social distancing. It's as if it's business as usual. So there's a whole variety of ways that people are dealing with these things, and yet they are not necessarily, but when they stop to think about the things they do in ordinary life, in their daily lives that they've done before, they don't see those things as particularly risky activities, which is interesting. So we probably have different risk tolerances for different activities and different endeavors that we take in our lives and different initiatives, right? Which is, normal human behavior. But I think what this will do is when we stop to think about risk within the context of a healthcare encounter, within the context of a healthcare setting for particular diseases or illnesses, trying to get that decision a little bit more anchored around what is this person's risk tolerance and risk appetite and the risk threshold. Maybe a helpful tool in the future, and emphasize the future, in terms of developing better decision aids, or improving our decision aids, and improving really the conversations we have with patients.
Thank you. That's
Any
really
other
helpful.
questions? Thank you for that question. Any other questions or comments before we take a break? No? Okay, so we are going to take a brief break. And I think it's about, I'm just making sure to see if there's anyone else who's entered into the waiting room, if there's anybody else I need to welcome. No? Okay, we're going to take, you want 10 minutes or 15 minutes? 15 minutes? Okay, 15 minutes. So let's get back here at 3 o'clock. Or actually, sorry, what I'm just looking at the time here. Yeah, 3 o'clock. 10 minutes, I guess. 3 o'clock. Okay, is everybody back after your break? Can you all hear me?
Yep, sounds,
Yep.
I can hear you now.
Oh, perfect. Thank you so much for confirming that. Okay, should we wait a few more minutes, or is everybody back? Everybody's back, hopefully?
I'm back.
Okay. Anybody else want to confirm? I see a lot of, I don't see many videos up, so just wait a few more seconds. We may not actually take up the full hour, so we'll see, depending upon how we get into the discussion. Might give you back a little bit of your time. Maybe just a few more minutes, just to kind of give everyone a chance, hopefully, to come back. Oh, here we go. We're getting more people. Good. Okay, welcome back, everyone. Thank you for continuing to slog through with this, to slog through with me on this. And we will be able to take another break or try to end it a little earlier, as the case may be. So for this next part, I wanted to tell you about a different kind of a different method, if you will. I'm engaged in leading a team of implementation scientists as part of a large-scale grant, and the primary goal of this GO-PGX Genomics and Outcomes Data Bank for Pharmacogenomic and Implementation Studies project is to develop and validate a number of pharmacogenomic panels of tests to guide pediatric oncology treatment decisions, in particular to reduce or mitigate some of the more serious adverse events that we know can occur with various forms of chemotherapeutic agents, such as hearing loss with cisplatin or cardiac toxicity with doxorubicin, that kind of thing. And the way that this grant works, each project has to have what's called a GELS component, which stands for Genetics, Ethics, Legal, and Social, sort of an LC component, if you will. And so there's a team of genomic ethics, legal scientists, GELS scientists, a team which I have the privilege to lead. And we have a number of studies that are ongoing related to implementation of pharmacogenomics in pediatric oncology settings through the auspices of this Canadian Pharmacogenomics Network for Drug Safety, which is the brainchild of my good friend and collaborator, Bruce Carlton, over at the University of British Columbia. And what I'd like to do right now is to tell you about one of our more innovative studies that is part of this GELS grouping of projects, which is led by my colleague and good friend Jillian Bartlett. So Jill has recently taken up a new position as Associate Dean of, for Population Health and Outcomes Research and Professor in the Department of Family and Community Medicine at the University of Missouri, fairly recently, like as in a month ago, or maybe a little bit less. Anyway, I had initially invited Jill to present on her work on this work with Anthony's World, the role-playing game that you will hear about in a few minutes. Unfortunately, she had an 11th hour conflict, and so she's no longer able to present with us. She did, however, kindly share with me the slide deck. And, you know, since I am really familiar with this study, I am perfectly comfortable and happy to give the presentation on her behalf. However, because we typically need a couple of people doing this, we won't be able to demonstrate the Anthony's World game in real time as we had originally hoped to do. Jill is actually quite the phenomenal game master, and I'm sorry that you have to miss playing the game and have that interactive experience. So that was our initial plan. That's what we had. That's why I had invited her to present this course with me, to give this course with me, is because I, you know, wanted you to have that experience. But you can see her contact information is actually right here at the very bottom of the slide. And if you'd like to email her directly to find out more about this afterwards, you can do so. I'll also add it to the chat at the end of the course if you'd like to contact her directly. And of course, you can always reach out to me, and I know how to access her. So Anthony's World, giving a voice to young people and the value of pharmacogenomics. So she says she has no conflicts of interest to declare. This is the outline of sort of the revised outline of what I'm going to present today. I'll tell you a little bit about Anthony's story and about how this game came about. Introduce you to this role-playing game, this new role-playing game, as a way of providing health-related quality of life data, and just kind of give you a sense of how we go about collecting data for it. So the story of this research and why it's called Anthony's World began originally in the context of a research study that Jill was involved in with another colleague, Dr. Nada Jabadu, pediatric hemo-oncologist and her team at the McGill University Health Center in Montreal. And so it's a team that formed part of the International Childhood Astrocytoma Novel Genomics and Epigenomics Consortium. And the goal here was to develop a plan for the implementation of a laboratory-derived test that they were developing. And the idea of this test was to refine current diagnosis and treatment plans for high-grade glioblastomas based on genetic tumor typing. So this is really a horrible disease that afflicts some children. And I don't think you want me to go into the details of what that involves, but it really is a disease with, unfortunately, poor outcomes. So as an implementation scientist, Jill was working to figure out the best way to have this test included in current standards of care in pediatric oncology. And their early work with pediatric oncologists and palliative care specialists revealed an important barrier to the test being acted upon for treatment decisions. Certain clinicians believe that the removal of hope by not offering a chemotherapy option, no matter how futile, was more harmful to the patient and families than any adverse effects from actual treatment that was bound to fail. And what Drs. Jabado and Bartlett started doing was they started working with a patient and family organization based out of Toronto called Megan's Hug. And they traveled to Toronto and met with the families in 2014, I believe. And I know Jill has become very close ever since then with these patients and these families. And after presenting some background information on the research from Dr. Jabado's team, Dr. Bartlett asked the parents how they would want to receive news about this genetic test, particularly if it was the worst case scenario. And the answers they received were quite informative. So she was working with these cohort of families, parents, and people she's now quite close to. She stayed quite close to them, and really discovered that there were two challenges. There were two thorny challenges when you're working in the world of pediatric oncology, and these are documented fairly well in the literature. One is the belief that the removal of hope is more harmful than toxicity of futile curative treatment, and that's not necessarily what the families believed or not, but it's certainly a belief that a lot of clinicians have, a lot of pediatric oncologists in particular have. And then there was a second issue, which is the issue of mutual pretense that a child is not dying. And it's a very interesting issue because it's one that everybody who's involved in some of these tragic healthcare situations engages in. So the child engages in it for the sake of his parents and his family, his or her family. The family, the parents also engage in it, keeping from the child that he or she is actually dying, because of course, you want to try and keep a positive point of view. And again, the clinicians are also doing the same thing, the healthcare providers, physicians and nurses and others who interact with the family. So this issue of mutual pretense, which was actually first documented in the literature about 30 some odd years ago, in a book that Jill happened to read called The Private World of Dying Children, which is quite a heartbreaking book to read. So why is this role-playing game called Anthony's World? So let me try to tell you as best as I can. Jill tells the story much better than I can, but I'm going to do my best. Anthony was a young man who was diagnosed with brain cancer before the age of 12. He was treated and survived, but the cancer came back several years later. When the typical treatment did not work, he and his family were offered a treatment that worked for certain patients with specific genetic results. Anthony took the genetic test. So by that point, there was this genetic test that was available. And the genetic test indicated that this treatment was unlikely to work for him. Anthony was present in the room at the time that the results were disclosed, and he did not want to give up hope. As a result, his family paid out of their own pockets several $1,000s for him to take the treatment that the genetic test results said was unlikely to work. At the time, Anthony and his family did not have a lot of information from other families' experiences and wanted to do everything possible to try and cure Anthony, which is quite understandable. Well, as predicted by the genetic test results, the treatment did not work. Anthony passed away several months later. But before he died, he communicated to his mother, told his mother that he wanted to make a difference to other young people and their families going through this experience. Didn't know how, but he made that explicit wish. And to try and make a very long story short, Dr. Bartlett, as we started looking at this role-playing game, got the brilliant idea and asked permission from Anthony's mother to name this serious role-playing game after Anthony. So that's the basic story as to why this game is now named Anthony's World. And you can ask Jill why she's calling it World and not Game. There's a very specific reason, and I think it's a very good one. So that's really the story. I think it's a beautiful story. It's a story that shows how every little thing we do and everything that we're involved in really can make a difference, and that it's wonderful that Anthony and his mother, whom I personally have not met, but Jill knows quite well, have entered into this incredible partnership and relationship with Dr. Bartlett. So, in particular, so the questions that we're trying to answer really are: how do we provide information to patients and families and healthcare professionals as well as researchers on treatment options when you are dealing with a rare disease such as glioblastoma, or in many cases, a lot of the sort of childhood rare diseases that you encounter sometimes in pediatric settings, when there is no effective curative treatment, or treatments have strong undesirable side effects, adverse events, and when there's little information to facilitate shared decision making that accounts for quality of life as well as survival. Now, this initially started out as kind of an in-person, face-to-face data collection research project. However, thanks to COVID, we are now doing it. It's being now done virtually. So there's a need in particular to collect health-related quality of life information. This type of data is frequently found to be of poor quality and uncertain validity, particularly in pediatric settings, far more so in pediatric settings than in adult settings. And it's not always easy to obtain. And an important reason for that it has to do with this issue of mutual pretense, which is, in effect, you really cannot ask direct questions about HRQOL and getting that information, or in other situations where you have social mores or conventions that are particularly strong. It's really important to stress this whole issue of mutual pretense, because when you think about it, if everyone's pretending that the child can't possibly be dying, then asking questions about pain and its severity, or what other things a particular patient might value, that might make something important in their life, whether that's wanting to play a sport or a musical instrument or whatever it is that they value. What they really think about, for example, having several rounds of chemotherapy is another example, that all of those types of questions become nearly impossible. So it really does become very, very challenging in this kind of situation to collect health-related quality of life. So the answer then to trying to get at this problem is to develop this game, which is what they've done. Okay, so Anthony's World is a role-playing experience where people of all ages, so the pediatric patients, not preschoolers not necessarily, but certainly 8, 9, 10, 11, 12, 13-year-olds and teenagers, as well as their families, as well as healthcare professionals. All of those people, particularly patients and families who are not currently dealing with a cancer diagnosis, what they do is they take on different characters and debate their preferences for treatments based upon not themselves, what they themselves would want, okay, but on their character, the role that they're playing in this role-playing game, in Anthony's World, in this character. So I'll show you what that looks like in a minute. And they're basically assigned these characters. So if you are a healthcare provider, you will not be assigned the role of a physician or a healthcare provider. You might be assigned the role of a patient, of a 12-year-old child, for example. If you are a parent, you might actually be assigned the role of a healthcare provider. So that's kind of a key component of playing this game. Because when the life of a child is on the line, it's really, really difficult for people to express their preferences between quality of life versus the chance of being cured no matter what. And this is particularly true because of this mutual pretense, but also because we are talking about children, okay? Which is very different when you think about health-related quality of life in adult populations and particularly older adults, right? And that's true even when the chance of a cure is highly unlikely. No matter how unlikely, the possibility is quite low. So taking on the role in a fictional world, people are able to express their views a little more safely, okay? And it's really quite a treat to see this in action. I participated in some of the beta testing for the virtual aspect, because we had to do that as well in order to see whether virtual data collection works, and it does, which is great. Another thing that's interesting is we can provide data that's mapped to a validated economic benefit. There's a tool so you can actually link those two things together if you're interested in HEOR kind of work. We can quantify health-related quality of life in vulnerable populations where data collection during a clinical visit might be difficult. Importantly, this is a tool, Anthony's World is an interesting experience that can facilitate education and engagement among a healthcare team and among patients and families. So this is being done within the context of this Go PGX project that I spoke about earlier. So we are using a number of test cases. 2 of them are cisplatin and doxorubicin to treat, that are used to treat neuroblastoma. And we're using a pharmacogenomic panel to test for, to get information on risk related to autotoxicity and cardiotoxicity. So let me show you what this looks like. And this is different than the heat maps that I showed you earlier, but it's a little different. But this is actually a real result from an actual patient. Everything is of course, anonymized and confidential. But what you can do is you can take these you can do pharmacogenomic testing, and you can get a sense whether someone, based upon their genetics, is going to have, what is their risk for autotoxicity. Okay, so in this case, we're seeing a fairly high risk for autotoxicity versus some other patients who may not have the same risk. Now, if you can see what this shows you in this slide as an example. So the hypotheses for this particular research study are the following. Baseline health-related quality of life data will impact treatment decisions. So will adverse effects profiling, like we're doing with the pharmacogenomic panels. The values that a character has, and the preferences that a character has, and you'll see what I mean in a minute, whether they're very musical, for example, or very sports-oriented, will influence what they think about in terms of adverse events and how well they tolerate adverse events. And this additional information that's provided by precision medicine tools, such as pharmacogenomic profiling, on risk of adverse events or effectiveness of impact of treatment choices is going to also have an impact. So let's take a look at Anthony's World. So what happens here is if we were to play this, which unfortunately, sadly, we're not, what we would do is we would assign you one of these roles. So somebody might be Dr. Mark Morrison, who's a 52-year-old medical geneticist. There are certain characteristics, not just demographics, but what are called, I guess, psychographics. So the idea of who is this person, what makes them who they are. And you can see from the slide, if you're reading it carefully, what those are. So he's a genetic researcher who specializes in diagnosis, spends his time understanding what works and what doesn't work for a patient, etc. You have Kathy, who is age 38. She's describes herself as being structured, hardworking, high energy as a parent. She has a part-time job 3 days a week to be able to take time to manage family life, and has organized everything to run like a well-oiled machine. There are a lot of details of our daily lives to juggle. I make sure it all gets done by waking up before the family does, to have everything in place for the day. If something were to go wrong, then the whole system breaks down. And then there's at the bottom of each of these cards, so the way it would happen, when we assigned you each of these things, is we would give you these personas. Okay, so if you're not an actual parent of a child with an illness, we would assign you to be the parent. And you would have, and each of these cards has these types of personas. And at the bottom it talks about, I'm most comfortable. Sometimes I feel sad in what the situations are. Sometimes I feel worried, and then home to hospital. And then Russell, of course, is the Russell is the patient who's aged 18. He is creative, sensitive, thoughtful. He plays drums in a band. We just started playing together. I would play music for the rest of my life if I could. You would often find me walking around with my headphones on, listening to all types of music for inspiration. and he says, I dig into my pain for inspiration, and when things get tough, I call up the band for a jam session. Okay, and then this tells you a little bit about I am most comfortable and what are the characteristics there. I have a lot of energy. It's easy to do my usual activities, yes or, and there's a spectrum and that sort of thing. So this is how Anthony's World is as a serious role-playing game is played, and how we collect the data. We provide each of the group that, so each of the group that is currently playing, and this is what we would have done with you if Jill was here, would be receiving one of these cards, one of these personas, and would take on that persona, and then we'd ask you to share about who you are by reading off the card, and we'd ask you to take on that persona. And then we kind of break you up. What we do to kind of get everybody in the mood of things, if you will. We use the Zoom breakout rooms, and have two different groups having different discussions on certain topics to begin to really get into the persona. And then for round one, so there's 2 rounds to this game. The first round talks about what it's like to, we give you this scenario of becoming a patient. So this is treatment preferences before you get pharmacogenomic results, before any kind of precision medicine is involved. And we talk about what the treatments are. What is treatment 1 versus treatment 2, treatment 3, treatment 4, treatment 5. And they each have different aspects of it, right? They each have different risks associated with different adverse events. So in some cases, you've got a treatment that might actually potentially be better at either being curative in terms of the cancer, but perhaps it really might affect your hearing. And then we give you this form. And we talk. Okay, and you're asked to fill out in real life who you really are, and in Anthony's World who you are. So you're who you are is your avatar, and we talk about the situation. So the first decision is, how do you feel after receiving or delivering this news, depending upon who you are, what your persona is, right? You either received the news or you delivered it, depending upon whether you're the physician or the nurse or the healthcare, whatever you are as a healthcare provider, or whether you're a parent or the child. And then we get you to rank, if you'll see at the bottom here of this form, there's a system where you rank the treatments. Do you want treatment 4, 2, 3, 1, 5, and then you kind of give us the reasons why you ranked those in those orders. So you kind of think through your reasoning. So you can see that Russell, for example, who is a musician, might actually be more concerned about a side effect of autotoxicity, an adverse event of autotoxicity. Now, this is before Russell receives any kind of genetic information, right? But you can see how that kind of information, which is really quality of life information, could come out in something like this, right? And we're not playing, again, with patients who actually have this particular, disease, that not someone who has a neuroblastoma. And the person playing Russell is probably someone who's not an actual patient, right? That's how we purposely do that. And the reason for doing it that way is to really allow people to take on this role and to start to see things from a very different point of view, from the point of view of the patient in a much more comprehensive, holistic way. So that's kind of the first round. And the second round involves actually getting the test results. And it's kind of done randomly, where Jill will literally, if she were here, hold up, 2 yellow cards and ask one of you on the call right now to pick one, the right hand versus the left hand. And depending on which one you pick, so let's say somebody picked what was in my left hand, and you got this, right? Cisplatin, low risk, doxorubicin, high risk. So what does that mean? So this means that now we're playing with a different important piece of information. Now Russell has taken this genetic result, and we know that there's say a low risk of experiencing hearing loss but maybe genetic test results of genes that increase the risk for experiencing cardiotoxicity, heart problems, right? And you can see what the numbers are. 15 and 100 patients will experience hearing loss if they receive this medication versus 80 and 100 patients experiencing cardiotoxicity. Now, after that round, we ask people to do another ranking. Okay, so we take the same decision that's on the right side of well, it's on my right side of the screen. Hopefully it's on your right side as well, where it says, who are you, decision 1, except now it says decision 2. And what you do is, with this new information, this new pharmacogenetic information, how do you rank these treatments? That's how the game is played, certainly in a virtual environment. And what are the reasons that you're now ranking the treatments? And what's interesting is we find people do change their rankings, not all the time, but the majority of the time, people do change their rankings for the treatments based upon the genetic information, and they're able to articulate that say, now I know that I won't, it's important to me not to get hearing loss because I think jamming with my band is really important, or whatever other quality of life issue they might be concerned about. As Russell, not as me, as the person, as Amalia or whoever it is, but as the persona I've taken on. And then the final thing is to do kind of a consensus discussion where we all have to, whoever's playing this game, all of us have to figure out which treatment will actually be, we will decide upon to be administered. And if for some reason we cannot come to a consensus, the rule is that the person playing Russell gets to decide. So let me go back to this thing here. And so what this gives you is a ranking of preferred treatments. What this tool, what this role-playing game, Anthony's World, gives you is a ranking of preferred treatments, a ranking with the pharmacogenomic test results, and then ranking by role and real-life characteristics and experience. We are able to use that data to contribute to an economic analysis, because there's an economic analysis that's being done in collaboration with Bruce Carlton's team at UBC, at University of British Columbia. We are able to hopefully, and then of course the future goals for this project are to develop shared decision-making tools and particularly provide education, provide it as an educational tool in medical schools, okay? Because we see there's real value, as you can see, for something like this to be a terrific tool for use in educating physician or medical students, as well as medical residents and others as pharmacogenomics and precision medicine in particular become increasingly a part of our healthcare systems and become more integrated into standard of care protocols. Okay, so that kind of wraps up the summary, or what I wanted to share with you about Anthony's World. I'd like to spend some time now taking questions. Like I said, I wish Jill were here so that we could all play this game together, but unfortunately that did not happen, but maybe there'll be another opportunity in the future. So what I want to do right now is to spend some time just taking some of your questions, either about Anthony's World or about the concepts that I presented earlier. And then the other thing I'd like you to share, if you are so inclined, is some of your ideas and thoughts about applying different tools to your research or your clinical practice in terms of decision-making tools. So, and actually probably stop sharing so that we can all have a good conversation like that. So here we go. Now I can see everybody all, and if I can ask those of you who are still on, who still don't have your videos up, it would be great if you don't mind putting your videos for this portion of the course. That would be great, please. If you're really uncomfortable, super uncomfortable, I'm not going to pressure you, but if you don't mind doing that, it would be really lovely. So who would like to speak first? And again, questions, comments, thoughts, and then we'll get into a bit of a discussion about your ideas about using different tools for the types of work you do. Oh, sorry. Okay, Randy's saying, sorry, video not an option for me. That's okay. Thank you, Randy. No worries.
So I guess I can talk about a little bit. I think what you just covered with the brain tumor with children is kind of very similar to the ideas that I've kind of conceived for my research here. We're kind of going to be trying to design somewhat like a decision support system that kind of takes in patient, like, data from trials as well as database research to kind of create some sort of AI-ish output for predicted responses. And then I'm really interested in seeing sort of the patient side, like what do patients value when they're trying to make difficult decisions, and when there are multiple, in our field, it used to just be one or two different options for treatment for some of these recurrent cancers, but with new molecular targets and genetic data, we have so many more options, and providers and patients, understandably are confused about what the best option is. Not that, anyone's getting any bad medical decisions now, but it'd be nice to create that sort of, I also envisioned that heat map of kind of patient fills out information, they want this, this, and this, and then here's how I think you would respond, and where do you fall in that heat map based on your preferences and your disease characteristics. So I think it was really nice to see it in another area. I think it's a new way to, show this sort of data, and it was really nice to see. Thank you for sharing that.
Thank you. Anybody else?
Hi, it's Anne. I had a question. How do you collect the data? Do you run the groups in do you have 100 different groups doing these scenarios? How do you figure out what's a good sample to use when you're collecting data like this? Because there might be variations in outcomes depending on, if you have 3 actors in each different scenario. I'm sure if we did the game, we might end up coming up with different outcomes. So how do you then, sort of gather all that? And do you repeat this with, is there a nice, round number that you use? Do you do it 500 times with, different groups?
So it's not 500 times, but what's interesting is, this would be a very highly selective group audience, right? Because we all know the tricks and tips about decision making. So we're probably not the best group to actually run this with for data collection. Although it's a lot of fun to do, and I've done it a number of times, and it's really quite something. And you really should watch Jill, as she. Like I said, she's a phenomenal game master, as she really, runs this. But one of the things that it is different groups. We try to include people from, who different ages. So there's different ages that are included, different genders, different, teenagers, children, young people, also, children up to a certain age. Healthcare professionals, different healthcare professionals. And again, if you are the healthcare professional, you're not going to play the healthcare professional role. You're going to be assigned a different role, that kind of thing. And the whole point of that is really to see the dynamic of engagement that happens. And yeah, it has to be done with a number of different groups. It is being done through this GoPGX project right now with a number of there's a number of people who are participating in that mostly throughout Canada, throughout the entire country. It's a pan-Canadian thing. And so it's going to be, initially the idea was to go and run them in a few different cities. Now I guess we've opened that up a little bit more with the opportunity for virtual using video conferencing to run these. And it's been, beta tested a few times now, and I participated in at least one of these beta tests, and it works. So it can be done through something like Zoom.
Yeah, I have a question, like how, this is very, very interesting too. So have you considered about the impact of time, like the value of characteristics may be changed with time. So especially for, young age patients. So have you consider or incorporate consider the impact of time for you too?
When you're talking about time, are we talking, tell me a little bit more
like
about what you're, let me understand.
Like the change, like the value, or, the value can be changed, or their beliefs or perceptions can be easily changed by, with time, like for example, by their disease progression or treatment effect, or, and also like maybe gain the knowledge about the disease or the treatment.
Sure. So as they get, so the way this is designed, and you would have gotten a much better idea if we'd been able to run it, but the way this is designed is really to get have a discussion going, a dynamic, engaged discussion going between people who've taken on the roles of a patient, a parent or two parents, and a different set of healthcare providers. And it becomes a real discussion. People ask questions. They say, here's what I'm concerned about. Someone comes back and says, well, now that my disease has progressed, here's what I'm concerned about. But what's really important, before mom and dad, it used to be really important to me that I got all the chemotherapy you said I should have because I really wanted to be cured. But now I'm seeing that there's, that there's limits to that chemotherapy, but I'd really like to spend some more time, playing on, being part of my softball team or whatever it is, okay, or jamming with my band, just use that example we used. So a really rich, dynamic, engaged discussion ensues and takes place, and because of that, people are able to, you sort of, it incorporates that. Now, admittedly, this isn't something where we're doing this over a 5 or 10 year period. Okay, this is just, we're doing this with one group at a time over the life of a grant, which is, of course, the way we all operate in academia. So there is that limitation, right? It isn't like we can use the same group of people and come back 2 years later and give them the same, do the same role playing again. But nevertheless, I do think you do get a good idea because the data is so rich, because of that dynamic, engaged discussion that happens.
Yeah.
But thanks for that question.
Thank you.
Other questions? More comments? Anybody else want to share some other information? How about somebody who's been a little bit more quiet? Is there anybody who'd like to speak a little bit more? Or maybe just give your overall thoughts on both presentations. Kristin Mackey, maybe? Haven't heard from you much.
I feel it's a silly question, so I wanted to give other people a little more time if they had others that were maybe more pressing. But how long did it take to put the role-playing game together?
Oh, Jill and the whole team has been working on this for quite some time, and she worked with design experts, people in design thinking. So it was quite the process. And she didn't provide me any of those slides, but it's very interesting to see. I mean, the initial part of it, So it's been at least a couple of years. It's been interesting to see the progression of this game and how it's been developing. You know, there's I have a picture somewhere where you know, of her standing at a cork board with a bunch of post-it notes, colored post-it notes. I mean, it's that level of designing this. And so now it looks a lot more now there's like really nice fancy cards that go with it. If we were to do this game in person, they've had to make some alterations in terms of doing it virtually. But if you're doing it in person, there would be these nice fancy cards that are printed nicely and everything else. But where it started and where it is now has been very impressive to see.
Yeah,
so it takes some time to develop this kind of thing.
Yeah, it would be just such a huge project. So.
Yeah, but it's also been a lot of fun. It's really a lot of fun though. And you get to work with a whole variety of people and get to test and retest and try different things. And it's and the other piece of it is that you know, like I said, you bring on people like people who are involved in user research or user experience research and design thinking, which, you know, is great to learn from them as well. So it's really can be a lot of fun to do something like this.
Yeah, I bet. Thank you.
Anyone else? Any other questions or comments? I know it's getting late in the afternoon and probably even later that in the Netherlands. So I guess what I'd like to throw out for all of you as kind of a final question is what are some of your thoughts on kind of novel approaches to doing decision-making research and engaging patients and development of tools or approaches? So that's one question. And, you know, do you have any has this seeded any ideas, I guess is another way to put it.
I would say that I don't necessarily, I wanted to join in this course to kind of learn how to integrate that patient perspective into our objective sort of decision science. And so, I'm happy to hear from others who have more experience, who have other ideas, who collaborate or anything, share knowledge. I think, this is a great sort of network where people share great ideas and can really affect other sort of fields. Going into fellowship, I came to University of Chicago because there's so many foreign, groups. There's a decision science at our Booth School that I'm, hoping to work with. And, this is another outside of my, GYN oncology bubble. I think, this is a great place to learn from others and maybe bring it into our world where it's so foreign.
Okay, well, let me do this then. What I'm going to do, if all of you don't mind, is I'm going to send out another email to all of you, and I'll use the blind copy again, and I will specifically ask you in that email whether you are okay, if you give me permission to share your emails with each other. So I don't want to do it without that explicit permission. So I'll send out an email within the next day or two to all of you, and I will ask that question. And those of you who do give me permission, please respond back with an email saying, yes, I give you permission to share with the group my email address and my information so that we can, be contacted. And if anybody wants to, start up a LinkedIn group or do something to kind of develop a kind of a bit of a networking community to kind of be able to continue these conversations, I'm certainly open to that and welcome that. I don't have the time or bandwidth right at this time to actually do that just yet, but I'm certainly supportive of anybody, like any of the students on the call who would like to do that. But I'm happy to do that as well. Yeah. So, and yes, Randy, I will definitely send you my initial email since you registered late. I will have to get your email in order to do that, though. I'm writing down your name. ask, okay, here we go. He just sent it to everybody. Thank you. Right, most of us don't have the secrets, but you still have to ask. What I will do though is I will ask the organizers to give me a list of the course registrants, the final list, and then we will, and I will definitely send out that email. And again, if anybody wants to, put together a LinkedIn group or something like that for us to continue having some kind of conversations in networking, I'm happy to support that in any way I can. I just, like I said, don't have, to be honest, have the time or bandwidth at the moment to do it. Maybe in the future I might, but I just don't at the moment. Are there any other questions or comments or thoughts that you wanted to share? Or if you wanted to give me some feedback also on this course and presentation, or the presentations, that's also very welcome. Because I do hope to try and do more of this in the future. No? Okay, well, I'm going to encourage you to enjoy the rest of the SMDM virtual annual meeting, and also encourage you to complete the course evaluations, which I know SMDM sends out. I will not see who filled out what, but it is always good to get the actual feedback, because it does help us improve this kind of offering. It's been, it's been a real pleasure. All of you have it's been really great. I really appreciated the conversation, the discussion, the thoughtfulness that you brought to today. Thank you for joining me. I think it's been just absolutely delightful that you registered for this course, and I really appreciated many of your comments and questions, and hope you enjoyed this. So hopefully we'll do this again soon. So,
Thank you.
Thank you.
Good day.